Hello and welcome to my channel. In this lecture we will be discussing the nerves on the posterior abdominal wall. So let's begin. Like any spinal nerve, the lumbar nerves composed of dorsal roots and ventral roots. Remember the dorsal root ganglia on the dorsal roots. The dorsal roots convey sensations to the posterior horn cells of the spinal cord. This is the intermediate horn. Remember the one we talked about in sympathetic outflow from T1 till L2. So in upper 2 or 3 lumbar nerves, you will find white rami communicantis. That is the outflow of sympathetic. See that? White ramus communicantis to the sympathetic chain, and from it a gray ramus communicantis to the nerve to distribute the sympathetic outflow with it. And then the nerve divides into dorsal rami and ventral rami. Now the dorsal rami go to the back, divide into medial and lateral branches. The medial to supply the multifidus muscle, and the lateral to supply the erector spinae and skin of the back. Remember these, the dorsal rami, and they do not form any plexuses. Different than the ventral rami, they are joined by gray rami communicantis from the sympathetic chain, and the upper 2 or 3 have white rami communicantis, as I told you, because they receive part of the outflow of the sympathetic outflow from the spinal cord. Now the ventral rami form the lumbar plexus. The lumbar plexus, as you can see here, formed by L1, 2, 3 and upper part of 4, joined by a branch from T12, and it's formed in the substance of the psoas major, because the psoas major origin, right anterior, right lateral to the, or facing the intervertebral foramina. So the nerves grew out of the spinal cord and found themselves in the substance of the psoas major. Now formed by the 1, 2, 3 and the upper 4, the rest of 4 forms the lumbosacral trunk, as you can see here, to the sacral plexus, and L1 receives from T12. L1, as you can see here, bifurcates to upper branch and lower branches. The upper branch gives the iliohypogastric and the ilioinguinal nerve, which is considered the collateral branch of the iliohypogastric nerve. The other branch of L1 with a branch of L2 forms the genitofemoral nerve, and rest of 2 and 3 and 4, part of 4, divide into anterior and posterior divisions. As you can see here, the anterior divisions of 2, 3 and 4 join to form the obturator nerve, from 3 and 4 to the accessory obturator nerve, and the dorsal divisions of 2 and 3, as you can see here, divide into smaller branches that form the lateral femoralcutaneous nerve, and the bigger branch from 2 and 3, and joined by 4 posterior division to form the femoral nerve, which is the largest of the nerves formed, and descends in fascicles before not united as a one nerve, fascicle of nerves in one bundle. So this is the arrangement of the lumbar plexus. The branches of lumbar plexus, muscular branches, T12 through L4 to quadratus lumborum muscle, 2, 3 and 4 to psoas major muscle, as we studied before. The iliohypogastric nerve, it's this nerve, iliohypogastric nerve, see that? Goes laterally on the quadratus lumborum muscle below or behind the lower pole of the right kidney and the left kidney as well, pierce the transversus abdominis aponeurosis and becomes between internal and transversus abdominis, Then divides into lateral and anterior branches. The anterior branches go through the neurovascular plane and gets out to supply the suprapubic skin, the suprapubic region. And the lateral branch, it supplies the posterolateral gluteal skin. This is how the iliohypogastric is distributed. The ilioinguinal, we will discuss this now, ilioinguinal, see, it's the collateral branch of iliohypogastric. Instead, it pierces the transversus abdominis and then runs between transversus and internal oblique, then pierces the arching fibers of the internal oblique and to become part of the inguinal canal below the spermatic cord or the round ligament of uterus, and then comes out of the superficial ring and supplies the skin of the upper medial thigh and anterior scrotal skin or root of penis and the root of penis, like the mons pubis and labia majora in the females. This is the story of the ilioinguinal nerve. Remember, it's the collateral branch of iliohypogastric. The genitofemoral nerve, on the other hand, L1 and 2, emerge from the anteromedial border of the psoas major. As you can see here, it's on psoas major, with the ureter and the gonadal vessels on top, superficial to it. The ureter was between the genitofemoral nerve deep and the gonadal vessels superficial. Now it descends and divides into genital and femoral branch. The femoral branch, as you can see here, remains lateral to the external iliac, passes under the inguinal ligament and supplies skin over the femoral triangle, while the other branch, which is the genital branch, crosses the external iliac artery, as you can see here, and goes into the canal and gives the cremaster muscle and ends by supplying the skin of the scrotum, like the labia majora in females. This is the genitofemoral nerve. The lateral femoralcutaneous nerve, on the other hand, which is this nerve, see that? It goes on iliacus muscle behind its fascia. On the right side, it has the cecum in front of it. On the left side, the descending colon in front of it. And it's deep to the fascia and then passes medial to the anterior superior iliac spine. This is one of the questions. Passes medial to the anterior superior iliac spine, either through or below the inguinal ligament. And here it has a chance to get entrapped, pathology we name as meralgia parasthetica. There is tingling, numbness sensation in the anterolateral part of the thigh because of entrapment of this nerve. Anyway, it descends to the thigh and divides into anterior branch that covers the anterolateral surface of the thigh down to the patellar plexus, and a posterior branch that supplies till the middle of the thigh. This is the distribution of the lateral femoral cutaneous nerve. The obturator nerve, it's from the ventral divisions of L2, 3, and 4, descends, as you can see here, it goes to the thigh to supply the adductors of the thigh. It has a story down there. The femoral nerve as well descends on the iliacus behind its fascia, supplying the iliacus and then pectineus here in the thigh, and then goes in the thigh outside the femoral sheath, not as a part of the femoral sheath, and descends and continues its story down there by its divisions. This is the obturator and the femoral nerve. Now about the lumbar sympathetic chain. The continuation of the thoracic, of course, it has 4 to 5 ganglia, runs on the anterolateral surface of the vertebral bodies, as you can see here. It's anterior to the vertebral bodies, medial border of the psoas major, anterior also to the lumbar arteries and veins, anterior to them. Overlapped on the right side by the inferior vena cava and on the left side by the para-aortic lymph nodes, has 4 to 5 ganglia, all give greater communicantis via the lumbar arteries, plexus around the arteries. And upper 2 or 3 ganglia receive the white communicantis, as I told you before, as part of the sympathetic outflow. Give force lumbar splanchnic nerves, as you can see here, the lumbar splanchnic nerves. The upper one for celiac plexus, the second one for the superior mesenteric and inferior mesenteric plexus. The third and fourth go down, to the inferior mesenteric and the superior hypogastric plexus, the one you find here between the bifurcation of the aorta. This is how the sympathetic extends its supply downwards into the pelvis by the superior hypogastric plexus. Okay. The celiac ganglia, they are on the cruri of the diaphragm behind the suprarenal glands. Remember this, behind the suprarenal glands. And the right is also overlapped by the inferior vena cava. The left one is overlapped by the splenic vessels. And there's a lower detached part, as you can see here at the beginning of the urinary artery. This is the aorticorenal ganglia, the lower detached part. The function of the ganglia is as regulatory center for the visceral reflexes. It's called the little brain. It has to do with regulating the pre and postsynaptic levels of visceral reflexes. The celiac ganglion, remember that from the thorax it receives the greater splanchnic nerve, while the lesser splanchnic nerve goes to the aorticorenal ganglia. Remember those? And the vagal fibers pass through the celiac ganglia without synapsing and spreading over the aorta with branches of celiac artery and with branches of superior mesenteric artery, and this will be the end of the influence of the superior mesenteric artery. Now, the superior hypogastric plexus, the one I mentioned, it's in front of L4 and L5, actually, and the promontory, and formed by the lower lumbar splanchnic nerves and the part of the aortic plexus, as you can see here. The parasympathetic outflow from the pelvic splanchnics, S2, 3, and 4. Some of them join the inferior hypogastric plexus, which is on the lateral pelvic wall, and then ascends through them through the presacral nerves, a couple of presacral nerves, or the inferior hypogastric nerves that goes to the superior hypogastric plexus, and from there it continues its ascent on the aortic plexus, and through the inferior mesenteric plexus the parasympathetic supply reaches the hindgut, which begins at the junction of the right 2/3 and left 1/3 of the transverse colon, the left colic flexure, the descending colon, the sigmoid, and the rectum. Remember that with the colon. This is how the parasympathetic supply reaches, by ascending on the inferior hypogastric plexus and the presacral nerves and the superior hypogastric plexus to the aortic plexus, and then from it to the inferior mesenteric plexus. Now, as all of you have noted, that the aortic plexus is the sum of all these plexuses, like the renal plexus, the front plexuses like the celiac, superior mesenteric and inferior mesenteric, like the gonadal plexus at the sides. So the aortic plexus, by which we mean all these plexuses together, because they are all a plexus, interconnected nerve fibers. Okay, and since we are used to the fact that sympathetic conveys sensory pain sensations from the viscera, So some of the sympathectomy procedures used to alleviate pain, especially in chronic cancer patients, the terminal patients with intractable pain. Sympathectomy is used as a line of treatment. Okay, this concludes the posterior abdominal wall and the abdomen, and we will start the pelvic walls with the pelvic osteology next time. I hope you got the maximum benefit from this lecture and from the series of the abdomen, and wish you all the best, and thank you very much for watching.